Another rainy April in Oregon and time for a Puscast. If April showers bring May flowers, what do May flowers bring? Pilgrims. I've always liked that joke. So this is a podcast that's going to cover the first 2 weeks of April 2012 in the infectious disease literature that I found released those 2 weeks. It's brought to you by Pusware LLC, publisher of the Infectious Disease Compendium, your uber hyperlinked electronic guide to infectious diseases, which can be found on iTunes, and my entire multimedia empire can be found at moremark.squarespace.com, where you will find links to my blogs and my books and my iPhone apps. And because, hey, the world needs more Mark Crislip. Should mention that I have no conflicts of interest and that all the references are online and that there'll be inappropriate smart-ass comments, maybe not, scattered in throughout. Like everything in my life, I do it for my own education and amusement. Hopefully you will be educated and amused as well. And don't forget when you're done to wander on over to iTunes and write me glowing reviews to feed my ravenous yet fragile ego. Now we will move on to the literature. That's actually not my mantra. My mantra is association is not causation. So we're going to start out with a pair of antibiotic toxicity publications. First up is quinolones. They always call them fluoroquinolones, but that takes too many syllables for me. I'm going to call them quinolones, or maybe quins, or maybe quin. Anyway, this article published in JAMA found an association between current use of quinolones and retinal detachments. They found that 3.3% of patients with retinal detachments were taking quinolones versus 0.6% for matched controls. Now, this is not a prospective study, but a retrospective case control study, so maybe not true. But it's something to think about. Quinolones do mess with collagen synthesis. They are associated with tendon rupture. And there's at least some biologic plausibility that quinolones could affect other parts of the body as well. They estimate that 1 in 2,500 people taking quinolones would have a retinal detachment and would account for maybe 1,400 cases in the United States each year. So, that's not very common, but still something to warn your patients about besides tendon rupture would be retinal detachment. And I'm sure it will not be long before you see some late night ads. Have you had retinal detachment? Call 1-800-LAWYERS. And a review of the issue that intermittent rifampin can cause DIC amongst other things. Now, most of the time we give rifampin daily, but there's some anti-tubercular regimens where you give your therapy once a week, or twice a week kind of deal with your rifampin. And if you give rifampin intermittently, you can get severe allergic reactions, including acute renal failure, hemolytic anemia, and a DIC. And this report is of a patient who keeps getting intermittent rifampin with intermittent DIC. Again, it's unlikely you're going to be treating somebody with an intermittent schedule with rifampin, but it can happen if you're an ID specialist, and it's a side effect to be aware of. I have vague memories that I saw a case like that once. Maybe it was the hemolytic anemia. I'm getting so old I can't remember anything anymore. The unfortunate thing about the influenza vaccine is those who need it the most are the least likely to respond to it, though perhaps the more likely to receive it. And those who will most likely respond to it are the least likely to need it and the least likely to get it. I mean, seriously, the people who we should really be vaccinating for influenza, given the efficacy of the current vaccine, is all healthy people in an attempt to prevent spread to the sick, the elderly, and the frail. There have been several studies to show that schools are an important amplification vector for influenza. Unfortunately, in the United States, doing things for the benefit of others seems to be passé these days. So if you're a dialysis patient, you're probably SOL. This study in the archives looked at the efficacy of the influenza vaccine in dialysis patients, and they compared the effects from both vaccinated versus unvaccinated in a dialysis population, where it only had an effectiveness of about 13% for flu-like illness. Remember that influenza accounts for maybe 10 or 15% of flu when there are flu-like illnesses. But when they compared it to a population which got the influenza vaccine when there was no match, they found that it had 0% effectiveness for influenza-like illness. Again, it's a bummer how poor the vaccine is for those who need it the most, and those who are most likely to protect their fellow citizens by getting the vaccine don't get it. For example, healthcare workers. My ideal flu vaccine study, however, would still be to vaccinate everybody west of the Mississippi and nobody to the east of the Mississippi, and then look at the efficacy of the vaccines in large populations. I, of course, live in the West, so that's why I want this side of the country to be vaccinated. I have lived through the excitement of 2 ward noro outbreaks over the years. I still suspect, but cannot prove, that one of the outbreaks was perpetuated by a bowl of M&Ms on the nursing unit that everybody was sticking their hands into. I don't know that for a fact, but it seems plausible. The question is, when do you let people come back to work? Because people can shed norovirus for a long time after they get over their clinical symptoms. This was a study out of the Netherlands. There seems to be a lot of infectious disease articles out of the Netherlands lately, or maybe people in the Netherlands are just doing interesting studies. I don't know. In this study, they looked at the nosocomial transmission of norovirus in hospitals to see who was passing on the virus. And they found that it was the symptomatic people that were doing the passage of noro, not the asymptomatic carriers. So most of the perpetuation of the outbreaks were due to people who were having ongoing diarrhea, both patients and staff. Which is nice to know, since I think norovirus is now officially the most infectious agent ever, with 1 particle required to start disease. So not only is it important to have good hand hygiene, but at least you know that when your staff are past their symptoms, they are probably past the point of infectiveness to others, and good hand hygiene should probably suffice. One thing I always do, though, now when I see a bowl of M&Ms or other candies on the ward, I always pick one up, lick it, and toss it back in. That way no one else gets the candy. It's all for me. I never heard of this bug before, which kind of surprises me, but then I'm always finding bugs I've never heard of before. So this was a study that was actually done partly in Portland, Oregon, and they looked at the causes of outbreaks of gastroenteritis. They had 142 outbreaks that they looked at carefully to see if they had infections due to sapovirus, the one I'd never heard of, adenovirus, astrovirus, and rotavirus. And they found that 23% of these gastrointestinal outbreaks that were not otherwise identified were due to sapovirus, with the majority, 2/3, occurring in long-term care facilities, which is a lot of diarrhea in long-term care facilities, and probably an indication they're not washing their hands well. Judging from the smells, when I've walked into long-term care facilities, I'm not certain that human bodily fluids are being appropriately contained. Human bodily fluids. Now, as a listener of this podcast, you are probably more up to date on your infections than I apparently am. But a sapovirus are calcifiviruses, and they cause usually viral gastroenteritis in children. It's called a sapovirus because it was discovered in Sapporo, Japan, just like norovirus was discovered in Norwalk. It is evidently mild but a common cause of acute gastroenteritis, both in young children and now in long-term care facilities. Although I technically live in an urban area, I sometimes think Portland is the largest village in the United States. On my daily walk, I go by sheep and chickens and llamas. And I do not live in the country. I live only a mile from the mall. One of the things you can get from these animals is orf, and I've seen one case of orf in my career from someone who acquired it from a sheep in the Portland metropolitan area. There was a report in the CDC of 4 cases of orf that were associated with, in some cases, the sacrifice of animals for Easter as well as for eating. These were from goats and sheep. It just points to the importance of a careful exposure history in patients with potential infectious diseases. I don't ask if someone has pets. I ask, have you been exposed to any animals? And then I run down the list of dogs, cats, goats, pigs, chickens, cows. And sometimes you hit pay dirt that way. Orf, in case you don't remember, presents with ulcerating skin lesions and or mass-like lesions that mimic tumor. And if memory serves, the planet that Mork came from. Wasn't it Mork from Orf? I just find this MMWR report amusing. A bat was on a commercial airliner. The bat subsequently flew around through the airplane. It was trapped in the lavatory. Is that the only thing that's called a lavatory these days, or the bathrooms on airplanes? When they landed, the bat then escaped. It flew out the cabin door through the airport terminal and was seen exiting the building through automatic doors. They determined that nobody was actually exposed to rabies as a result of this bat flying around inside of the airplane. Another TSA failure, I suppose. I've had to deal with bats 3 times this year at various times. Twice the poor thing flew into our ceiling fan and died as a result. But I know how hard bats are to capture in a big house, but seriously, if it's in an airplane, it should be fairly easy to catch. I now have 2 big nets at the house so I can catch bats the next time they show up. First snakes on a plane, now bats on the plane. That movie idea is mine, by the way. Remember, you only worry about rabies exposure if you've been exposed to the saliva of the bat, which did not happen in this case. The Clinical Infectious Diseases often labels their articles as major article, and sometimes they're not so major. But this one is very interesting. There's the N-methyl D-aspartate receptor that's found in the CNS. And if people develop antibodies against this receptor, the NMDAR, they get an encephalitis that presents with language problems and psychiatric problems. People act like they're crazy. I've seen one case. Usually it's people that have ovarian teratomas, and they develop antibodies against the ovarian teratoma, which subsequently cross-reacts with the NMDAR receptor to cause encephalitis. And if you take out the tumor, they usually get all better. This study looked at the frequency of this form of encephalitis in young individuals in the California Encephalitis Project. And they found that it was 4 times more likely than HSV, West Nile, or VZV, and in the kids was the leading cause of encephalitis, which is pretty remarkable. The actual numbers, out of 761 cases of encephalitis in people under age 30, they found enterovirus in 30, HSV in 7, VZV and West Nile in 5 patients, and a whopping 32 had the NMDAR antibody. So young children and women presenting with encephalitis, you should probably put that on your panel of tests to order. The physical finding of teratomas, the usual underlying cancer, is ovarian cryoauscultation. You put the patient in a cold room, then you listen over the ovaries for the teeth chattering. Old medical joke. Which is what I fear becoming most, an old medical joke. HPV, of course, is a cause of rectal cancer in men who have sex with men. This was a non-randomized trial, but in a clinic they gave patients the option of having the HPV vaccine or not. Those who had anal neoplasia who received the vaccine had less recurrence than those who did not have the vaccine. This is not a randomized clinical trial, but the difference in a year was quite remarkable. 13% in the vaccinated, 30% in the unvaccinated. They postulate that this is because the vaccine leads to a higher antibody response, which prevents further spread of the virus in at-risk patients. The zoster vaccine is approved in old geezers, of which I'm soon to become. But how about in the 50 to 59-year-old group? This study looked at the efficacy of the zoster vaccine in that age group. They had almost 23,000 patients. And zoster occurred in the vaccinated group 30 times, and in the unvaccinated group 99 times, for an estimated efficacy of about 70% for the year and a third they followed the patients. Those who received the actual vaccine had more pain in the arm. When should you recommend the vaccine? Currently, it is not recommended in that age group, and until they live to age 80, we're not going to know long-term efficacy. Having had zoster at the young age of 25, I certainly don't want it again. Certainly, like so much else, as you get older, everything falls to crap, to wreck and ruin. Because in the vaccine studies for zoster, if you were 70 and above, the efficacy rate was a mere 38%, where if you were 60 to 69, it was 64%, and if you're 50 to 59, now it is 70%. So it may behoove you to get it before you become a decrepit old geezer, which, the way I feel this morning, I'd say is about now. Coughing, of course, is an extremely effective way of spreading infectious diseases. The reason you have a patient turn their head and cough when you examine for a hernia is that they turn their head so they don't cough on you. It doesn't make the feeling of the hernia better by having the patient turn their head. That's probably left over from the TB era. At least that's my understanding of the turn your head part of the turn your head and cough. Somehow people don't seem to believe that coughing spreads disease because we always have to give people post-exposure prophylaxis for pertussis. Boy, there's a lot of P's in that sentence. And it costs money and time and hassle. This study looked at 2 strategies in patients who had had the pertussis vaccine, treat or not treat, and found that in both groups who were exposed to pertussis, no one got pertussis. So it brings to the issue whether or not you really need to give post-exposure prophylaxis to healthcare workers who are vaccinated to pertussis. The one caveat in this particular study is everybody had had the vaccine within the last 4 years. Currently, the Advisory Committee on Immunization Practices recommend PEP for all healthcare workers who are likely to expose high-risk patients, i.e. neonates, pregnant women, and if you ask me, my mother. A common cause of fevers that we like to refer to in the biz is the doxycycline deficiency state. Many of the things that cause fevers we can't grow or identify by standard technologies, and patients are non-focal. This study went to the rats of Los Angeles. Boy, there's a softball pitch there. And looked at 200 rats, and they found Bartonella rochelliniae and Bartonella tribocorum, if I pronounce those right, in 18% and 60% respectively. So in urban Los Angeles, the rats have Bartonella, and these are potentially human pathogens causing a doxycycline deficiency state syndrome. I suppose doxycycline would be a good drug to have hoarded for the upcoming zombie apocalypse when, amongst other things, the rats will multiply and take over the earth. Not only Bartonellas and mycoplasms, but Rickettsia are a cause of doxycycline deficiency states, and Rickettsia monacensis, monacensis, is a newly discovered cause of Mediterranean spotted fever illness. This one was in Sardinia. The number of Rickettsia that can infect humans seems to go up every year. Maybe we should just put doxycycline in the water supply. along with the greatly needed birth control and antidepressants. Every day, as I mentioned in reference to Mork from Orf, I go for a walk in my neighborhood, urban Portland, and I go by a field of sheep. And this spring, there's been half dozen lambs on the field. Lamb. Probably nothing better than leg of lamb with mint jelly. Anyway, every time I see the lambs, I think, if the wind's blowing this way, I could get Q fever. Unlikely, of course, but it does make you nervous. This study out of the Netherlands, which has been having a big outbreak since 2007 of Q fever, looked at the issues for people who go on to develop chronic Q fever, which is endocarditis as a rule. And they found that the people who developed chronic Q fever had a history of valvular surgery, valvular prosthesis, an aneurysm, interestingly enough, renal insufficiency, and older age. So at least I have one risk factor as I head into my old geezerdom for chronic Q fever. However, the data out of France suggests that chronic Q fever is more common than suspected, and anybody with acute Q fever should be followed closely for signs and symptoms of chronic infection. I always think that the true axis of evil is North Korea, Iran, and the Foley catheter. And so far this decade, more people have died from the Foley catheter than the other two combined. Well, that won't be true once North Korea lobs a nuke at the West Coast. I kind of wonder which city they'd target. Hopefully not Portland. Yes, I'm that selfish. But this study looked at other risk factors for the Foley catheter. And not only were urinary tract infections common, but genital urinary trauma was every bit as common as UTIs, with 1.5% of patients having some sort of trauma, of which 32 of the 100 cases led to interventions such as prolonged catheterization or cystoscopy. So the pathology from Foleys are much greater than just UTIs. And I definitely am not only DNR, DNI, DNF, and DNRT, which is do not intubate, resuscitate, Foley catheter, or rectal tube. I'm giving you guys too much information today, aren't I? Now, this is the most intriguing article this month. In this study, they took patients and they looked at their urine. These were females, and they did both transurinary catheterization and suprapubic aspirates. And then, rather than doing cultures, they used 16S ribosomal RNA PCR technology to see what was actually in the bladder. And in a significant number of patients, they found bugs in there that were both asymptomatic and weren't growable, if that's a word. The predominant ones were Aerococcus in about 50% and Actinobaculum, which was found in about 20%. The interesting thing is whether or not this is part of normal flora. If the bladder indeed has a complex microflora like the rest of the body, to quote the author of the study, who said, "We don't know how it got there. We don't know what it's doing there. We don't know whether it's related to disease or it's related to health," end quote. So somebody has a whole new area of research. But it'll be interesting to see over the next several years how normal bladder flora changes in disease and health, and what that normal bladder flora is in different populations. Salmonella has various subtypes. There is Salmonella subspecies 1, which is Enterica. There's 2, which is Salame. 3, Arizoniae. 3b, which is Diazeroniae. 4, Houtinae. And 5, Indica. Interestingly, in this study, patients who had Salmonella types 2, 3, 4 were more likely to have bacteremic diseases, wound infections, and abscesses than type 1 disease. So if you have a non-enteric Salmonella, you're more likely to have bacteremia and abscess. I think this is interesting, and it makes you wonder what the spectrum is between Salmonella type 1, Salmonella 2, 3, 4, Salmonella paratyphi, and Salmonella typhi. Since there's a spectrum of disease from just diarrhea to diarrhea plus bacteremia to the classic typhoid fever of Salmonella typhi. I wonder what the evolutionary relationship is between these organisms. But the practical take-home is not all salmonella are equal for causing bacteremia and other infections. Although the invention of cimetidine was the only thing that got me through my call nights as a resident, I used to get the worst dyspepsia in the middle of the night on call, and cimetidine was a godsend. But acid suppression has its downsides: increased risk for ventilator-associated pneumonias, increases your risk for C. difficile, increases your risk perhaps for community-acquired pneumonia, and now this study, retrospective, suggests that patients who are on acid suppression have an increased risk of SBP. Those on acid suppressant agents had 71% versus only 42% of controls, which is a lot of SBP in your cirrhotic. Cirrhosis is a bad disease. I'm pretty observant there, aren't I? This needs to be, of course, repeated in a prospective trial. Some of you may have heard me say this before as well, but usually after introducing myself to the patient, I say, what brings you to the hospital? And a significant amount of the time, the male says something like, my wife made me, or my girlfriend made me. And I've long postulated that the reason men live into their 70s is that our wives or girlfriends haul our sorry butts into the ER when we're sick, and we don't fester and die at home, blowing off the illness. And the study looked at the effect of marital status on elderly men who were hospitalized with pneumonia. And if you were married and came into the VA, you were less likely to end up in the ICU, more likely to go home, and have better mortality rates. Why might that be? Well, I would postulate this because married men get hauled in sooner than unmarried men, but you can't prove that. But it's interesting that marital status is associated with better outcomes, at least in this population, for pneumonia. Just a study that suggests you cannot be cavalier about pneumocystis spread. This study looked with molecular tests at an outbreak in renal transplant patients and found that colonized patients probably were spreading it to patients who then developed symptomatic disease. So being a carrier of pneumocystis puts you at risk to giving it to others in the renal transplant clinic. What to do about it at this point, of course, is uncertain because it's hard to know currently who's a carrier of pneumocystis given the small numbers of organisms found in asymptomatic patients. I think your best bet if you go into the waiting area of a renal transplant clinic is just to hold your breath. I don't know about your institution, but at mine, we get blamed for giving patients MRSA. They didn't have it before they came in the hospital, and they got it after they came in the hospital, and we get credited for it. Interestingly, in Chicago, they went and cultured them for Staph aureus, and they found that 69% of ambulances had Staph aureus isolated, of which 12% were MRSA. So maybe the source of the staph that your patient's picking up is the ambulance ride in. I really don't know what the infection control techniques are in the ambulance as people are rushed to the hospital trying to die. But certainly the issues as to where people pick up their staph is not as straightforward as we gave it to them. I watch all these less than clean patients wander the halls of the hospital, and I think, there's some MRSA coming into my institution. I'd like to ban all visitors, but they won't let me do that. A poster at the 22nd European Congress of Clinical Microbiology and Infectious Diseases suggests that daptomycin is a reasonably good drug for staph sepsis of all kinds. In this retrospective look at patients in a registry, they had cure rates of 72% for sepsis with Staph aureus and 85% of sepsis due to Staph epidermidis, most patients receiving 6 milligrams and some even 8 milligrams per kilogram. That's reasonably good data for patients with staph bacteremia. It's always a question with these rising MICs to vancomycin what the optimal drug is to treat bacteremias and staph. I personally don't know. I suspect that vancomycin is a second-line drug, and that perhaps we should be using daptomycin and ceftobiprole and its cousins first. What we really need, though, is a head-to-head clinical trial comparing vanco versus linezolid versus daptomycin versus ceftobiprole or one of its cousins in staph bacteremia, so we really know for sure what the right drug is rather than guessing. That, of course, is never going to happen. We don't think about it in the United States, but Chagas disease is found in California and Arizona. 55% of the vector carry Chagas disease, and in this study they found that 38% of the vectors fed on human beings. So they have the triatomine insects, if I pronounce that correctly, which are vectors for trypanosomiasis in Arizona and California. They are infected, and they do feed on humans. Although the curious thing about this study is that they found bugs that fed on humans, and they found bugs that had the parasite, but they did not find bugs that did both. Still, there is the potential of spread of Chagas disease in that part of the country, and may account for some, albeit rare, cases of cardiac failure in the American Southwest. And that brings us more or less to the end of this Puscast. The references are available on the website. This has been brought to you by Pusware, LLC, the publisher of the Infectious Disease Compendium, your Persiflager's Guide, your uber hyperlinked electronic guide to infectious diseases. Don't forget to go to iTunes and write glowing reviews to feed my ravenous yet fragile ego. And you can find links to all parts of my growing multimedia empire over at moremark.squarespace.com. This is copyright 2012 under the Creative Commons license. And that's it. As always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you in dictation. Goodbye.